So our next speaker is Dr. Lisa Liu. She's a public health and preventative medicine physician who has worked at the intersection of health, built environment, and sustainability for over 10 years. She has helped to advance the healthy built environment field through strengthening the knowledge base on the relationship between built environment and health, developing tools that bridge science and policy and practice, supporting the incorporation of a health lens in the development proposals, and building collaborative relationships across sectors. So Dr. Mu is the lead medical consultant for the PHSA's Healthy Built Environment Toolkit and guided the development of Metro Vancouver's Health Impact Assessment of Transportation and Land Use Planning Activities Guidebook. In her role as the Medical Officer of Health for Fraser Health Authority, she provided strategic leadership and direction to the health risk assessment, healthy built environments, global environmental change and climate change, and unintentional injury prevention programs. Dr. Mu obtained her medical degree from the University of Western Ontario and her specialty in public health and preventative medicine from UBC. She co-chairs the Ecological Determinants of Health Standing Committee of the Health Officers Council, a society of the public health physicians of BC. So I'm passing it off to you now.
Thank you so much, and it's a huge pleasure to be here. Thank you, Charito, for inviting me. And I am, like Charito, I'm super excited to see the folks who are joining us from across the country. A quick note of clarification, I was fortunate to be one of the public health consultants leading the work for the first version of the Linkages Toolkit, but I cannot take credit for this update. There are many, I was on the steering committee, but there are many people who were really, knee-deep in the data for this version. So I'm going to be sharing a little bit of my experience with the application of the toolkit from the perspective of two roles. One is a previous role as medical health officer for the city of New Westminster, which is one of the communities in Fraser Health region, and in my current role as a medical health officer working on public health and a public health response to climate change. So Charito already showed you this slide, so I'm actually going to just skip along here. Fraser Health Authority, which is this orange piece at the bottom of the image, is one of the fastest growing regional health authorities in BC, if not probably the fastest growing health authority. It serves approximately 1.8 million people who live in communities that vary greatly from fairly urban metropolitan centers to rural and small communities. It's a fairly diverse multicultural population, and there are approximately 38,000 First Nations living in this region. So here we have a couple of images just showing you how diverse that the geographic setting is, with the city of Surrey up top and the rural community of Abbotsford in the bottom. The Healthy Built Environment program at Fraser Health, so Charito introduced this actually, maybe I can skip along, but just to provide a little bit of policy context, the Healthy Built Environment program really emerged as a response to policy direction from the Ministry of Health. So many of us who are in BC will be familiar with the Healthy Families BC policy framework, which recognized among various health risk factors such as levels of physical activity, diet, tobacco use, the built environment as really a critically important determinant of health. And so the formation of Healthy Built Environments program fits within our overall Healthy Communities Partnership program that aims to work very closely with municipalities to basically address those upstream determinants of health, including the built environment. At Fraser Health, the program consists of 3.5 FTEs of staff and a manager. And those staff work very closely with the communities that they're assigned to. And, okay, so In terms of the use of the toolkit in the program, I would say that the Linkages Toolkit really has been a critical tool for the program. The program draws heavily from the toolkit when providing input to official community plans, neighborhood development plans, and other planning documents. They use the conceptual framework of the toolkit, of the 5 physical features. They draw on the planning principles, the health evidence quite significantly, and they also use a language that has, although looks maybe from the outset fairly high level, has actually been very carefully crafted to not overstate the evidence, but also to provide enough weight to provide direction and guidance. So the toolkit really has been a very critical resource. An equity perspective is woven throughout the HB principles, woven throughout the toolkit, and so in the application of the toolkit and HB principles that are in it, that lens gets applied as well. I would say also that often it is the health sector, not just at tables around built environment, but other tables where we're bringing forward that health equity lens. And I've definitely seen it in conversations around built environment and health. So the first example that I wanted to share with you today is the collaboration between the Preventive Health Authority and the City of New Westminster on the City of New Westminster's OCP update. The City of New Westminster is a fairly small community in Fraser Health. It's actually only about, I think, 6 kilometers squared in terms of the landmass, and it's one of the older cities. It's actually quite a highly walkable community. One of the unique features of this process was that the city and the health authority entered into a formal agreement to work together on this OCP update in the form of a letter of intent. And this really shaped and influenced the way that health was included in the OCP and in the process. And I also want to acknowledge that I saw in the participant list that Alex Kwan, who is an HB specialist with Fraser Health, is on the call today, and he was the HB specialist who worked on this update, and so this is really his work. So the LOI really reflected the city's commitment to health and the inclusion of health in the process. The goal of that collaboration was to determine best practices for integrating health language and evidence into the OCP, include a health lens in the OCP, and develop an OCP with policies which promote positive health for the community. And so we really see that reflected in the OCP's strong focus on community and individual well-being, the way that health is woven throughout the document as a consideration when oftentimes health will be sort of sequestered into one section of a document and is not integrated. We see health used in the framing of key goals and also driving policy and action. So of the 12 goals that were identified in the OCP, goal number 1 is actually an equity-focused or oriented goal to support community and individual well-being. And we see that here, policy 1.1, facilitate a more equitable and livable city in which all residents can meet their basic needs. Now, I don't know that the health involvement can necessarily take credit for that in this instance. The City of New West is very equity-minded, has a very, very strong social planning team. That being said, I think that you know, the health sector and the city working together here really produce this in a synergistic way. So here is an example of health being added into the context statement in that first paragraph up top. And again, I've heard from both the health sector and municipalities that including health in a rationale for policy really adds weight and credibility to the policy. It raises the profile of the issue. And I also have heard, and I share this, that in a way it also reminds the city that building cities which support health and well-being is really a key part of what we do. And historically, if we go back, urban planning really emerged from a recognition of the need for a systematic way of ensuring that cities actually promote health and well-being. Here's another example of health in the context statement. So here, this is from the healthy natural environment area, and really actually using a HBE principle that is in that section of the toolkit, advocating for increased access and engagement with green space. And then in the second paragraph here, you can see the city really responding to that call. In the city's goals, the OCP goals around housing, you can see that, again, there are already fairly comprehensive policies around housing, and that health is woven in here and really serves to strengthen already fairly strong policies. And this note around the policy around fostering social cohesion and connectivity reflects our increasing understanding of the importance of design in fostering social interaction and social well-being. Finally, just a couple more examples of how health and equity are included in some of the other goals. Okay, I'm going to move along in the interest of time. I see I have a few minutes. So I'm going to switch gears a little bit to talk about the use of a co-benefits lens. There are two ways to consider. One is to think about the co-benefits, the non-health co-benefits, such as social and economic co-benefits of healthy built environment principles or planning principles that we know are associated with positive health outcomes. And these are some of the things you'll see in the update and on the social and economic kind of considerations or contextual, considerations perspective. The other way to use this lens is to consider the health benefits, health co-benefits or even co-harms of non-health actions such as climate actions or climate mitigation or adaptation actions. And using this approach, the second one really, again, strengthens the case often for action and allows us to prioritize actions that will create the most benefits for health and for our other outcomes of interest, and also mitigate unintended consequences. This example is actually not one that I'm personally involved in or worked on, but I think is an excellent example of a health co-benefits lens being applied to a climate action plan. And quite frankly, most of us are just getting started in this work just starting to work with municipalities on it. So we look to work like this by the San Francisco Department of Public Health to really help us understand how we can work with municipalities, and they really have been leaders in this work. I have a couple of examples, and I'm going to, sorry, I'm just looking at the notes here. So, the climate action plan basically this is the climate mitigation strategy, and the Department of Public Health looked at 4 areas of action, including transportation and energy efficiency. And they assessed the strategy for potential health co-benefits and potential harms. I'm actually going to go to the next example because I think that's maybe one that we don't think as much about on energy efficiency. So what they found in their assessment of with all of these areas was that there's a significant potential for co-benefits, but also potential for harm. So, for instance, many energy efficiency practices and design characteristics, if they increase thermal control, improve ventilation, decrease moisture, and improve lighting, can significantly improve indoor air quality and lead to a number of these health benefits that we see at the top here. And in addition, there's increased or disproportionate benefit for low-income households. So there's a health equity implication there because they have then increased resources to meet their basic necessities. On the other hand, if energy efficiency measures are taken without attention to the need for adequate ventilation, moisture control, and the types of building materials that are used, which can release thoroughly harmful VOCs, indoor air quality can actually deteriorate. They also found that the energy efficiency programs that were being promoted by the climate action strategy left out renters because they were targeting home ownership. So this led to recommendations that then had the potential to strengthen the health benefits and also to mitigate some of the potential harms. So they included things like ensuring building materials that contain harmful chemicals are avoided and targeting energy efficiency upgrades to low-income neighborhoods, renters, and SROs. This example comes from closer to home. So this is a research study that the Preventive Health Authority is a partner to. This is a partnership between the health sector, so the Preventive Health Authority, the Lower Mainland Facilities Management, as well as researchers in urban forestry at UBC and municipalities including City of Surrey and City of North Vancouver. And the study really essentially intends to, it's just getting started now. Our intention is to build and test green infrastructure scenarios, so basically different ways of building green space into 3 different case studies, 2 hospital campuses and 1 I think park in the City of Surrey, with the intention to identify and develop recommendations for how to build green infrastructure in a way that really maximizes both health outcomes as well as climate mitigation and adaptation outcomes. And this project is being funded by the Real Estate Foundation of BC, and it was made really clear to us that it was a collaborative approach of the project and the use of a co-benefits lens, including health outcomes, that garnered support from the funder for this project to take place. So it's so I think it just reinforces for me the importance of bringing in that lens and that there really is value in these types of collaborations. So I'm happy to take questions at the end, and that's it for me.
Thanks, Lisa. Those were some fantastic examples. And so now we're moving on to our third speaker,